Started. Welcome to NP's Changing Practice. I'm Carol, and we have a wonderful guest today. Dr. Phares is with us, and you're a psychiatric nurse, right?
I am a psychiatric nurse practitioner, and I did start out as a family nurse practitioner, and then I went back to school and got my certification in psychiatry.
So I think that's what I'm interested in. So tell us a little bit, tell students that would be considering, people who are NPs or just coming into the psychiatric track, what attracted you to want to seek that second certification?
Okay, well, many years ago, probably around 1999, 2000, when I got my FNP, there really wasn't a lot of psychiatric nurse practitioner programs around. And so many FNPs worked in psychiatry, you were under the umbrella of the physician.
Right. Similar to acute care now. I mean, when I started, there wasn't an acute care program.
So that was basically, it was allowed, but so that's, I lived really close to a private psychiatric hospital. So I started there kind of helping on the side. But as a family nurse practitioner, usually most patients will come to you first before they see a specialist or a psychiatrist.
Absolutely.
And so I needed to know more information. And I began to see that it's very misunderstood. There's still a bad stigma about mental health. A lot of people don't understand it. I like to think of it as medical. And I tell my patients this too. It's your brain. That's just where your moods come from. So, you have heart, liver, if your pancreas doesn't make insulin, you're diabetic. If your brain doesn't make the feel-good chemicals, which are serotonin, dopamine, norepinephrine,
right,
then, you're depressed or you're anxious. If you're making too much dopamine, you can hear voices and see things that aren't there. So I always let them know that think of it as medical, and it's not just willful behavior. They
really have something that's wrong. And I do think you're right. There is that stigma that they think that they should be able to overcome it themselves.
Yes, get over it.
Get over it. Or why can't I get myself out of the dark?
A lot of people, you ask them a family history, because it's very important to know if there's a family history of especially bipolar disorder or depression. And well, no, we never talked about it. Nobody would ever talk about it if they did,
Right. They didn't want to.
So, and I still have the FNP in me, because even though I'm doing a lot of telehealth right now, it's very rewarding, because a lot of my patients may not have transportation. I'll give you an example. I had a patient who went to the ER months before I saw him. He was a new patient to me, and he had been told he has diabetes. Well, he never followed up with me. So I didn't have a car. I didn't have gas money. So I'm like, well, let's get you checked today. And the nurse came in, and oh my goodness, his blood sugar was way up there, way up there. So I sent him over to get medical care, and then now he's treated and he's more balanced. I had another patient, just from listening to her symptoms. So there's the FNP in me. I'm always asking about their mood, but I'm also asking other things. Holistic.
It could be thyroid. It could be
thyroid. So you need
underlying things that are causing them to feel that way.
Well, she was, fortunately, she had a caseworker with her. Her blood pressure was really low. You're going to the ER. She ended up having a UTI with sepsis, and they admitted her. So she was in trouble.
But now I worked in rural health for 7 years, and I totally understand what you're talking about. 50% of the cases that came through the door had an underlying depression, anxiety, and I was the only person that they had to touch with,
Yes.
Sometimes it was a transportation thing. I was the only person that, was in close enough proximity that they could go see, or the wait list was just so long to get them in to see anybody else that I had to start somewhere. And totally understand that feeling of, what do I prescribe? How much do I go? And you always start low.
Low. But
you keep going. But I think most primary people stay low. They just get them started, and they say, okay, are you good? I came across this one tool that I love, and I used it on my patients all the time, which is GeneSight. And
Oh,
they
yes.
had a representative come out, and we could collect, like it used to be, like you said, we would say, do you have a family history of a mental illness? Do you have anybody that had took any kind of medications in your family? Did anything really work for them? We were like guessing to find out which SSRI, which SSNRI would work for them, right? But with GeneSight, you got like a personalized little plan that said, these medicines, worked better for this person.
Yes.
You kind of had some guidance there. So, I mean, what do you think of that type of a tool?
Well, we have you're talking about the lab work. There's GeneMind is what I've used too. And
and there's probably other things. Ours had to do with the swab in their mouth, and then they got the DNA.
Yes, that too. Everything. And they'll kind of tell you which medications this patient will do best with.
Right.
And although I did have a patient, none of them worked on the reports. She was just very challenging. But they are also good for other medications too, like pain medicine.
Pain medicine, anti-anxiety.
And chronic pain and depression go together.
Right. And the folate deficiency, because people just don't have enough of the methylfolate. And I found that to be something to be aware of, because that it affected things. So how did you find that transition? Did you always work in psych, or did you work?
No, I worked in a family practice first. And then, like I said, I had opportunity to help out doing physicals, the head to toe physicals. When they come into a psychiatric hospital, they have to be medically cleared.
So what have you found the most rewarding as a psychiatric nurse practitioner?
As a psychiatric nurse practitioner, well, I absolutely love it. But I like I said, I still get to do the medical, I can order lab work, and I manage their medical diagnosis also. But watching people, you see their lives change. I mean, not just socially, economically, occupationally. They go back to school, they can go back to work. Some people are homeless and they don't want to live, and they're in great despair. And then they come back, they'll be sitting in your office crying. And then they come back, you think they're going to do cartwheels out of your office. You see them get better, you get therapy, you get the right medication. And sometimes
you have a therapeutic approach, which is what you really learn a lot of in the psych program, right? I mean, it's not just learning about the psychiatric medicines in much more detail, which I think is huge, right? It's just a really good tool to have know more about medications and how much. I mean, as a practitioner, I can remember patients coming to me that were on lithium, and I would need to renew their scripts, and it would scare the daylights out of me, because I'm like, oh my gosh, they didn't have any other provider until we could get them
kidneys, thyroid,
just all of that, and so some of them you just need to really know what you're doing with it, what's the best one. But as you said, you learn a therapeutic approach, which is a little different.
Well, you never have enough time with patients, no matter what patient is, but, they have a sore throat or earache or something, diabetes, you manage that. But you don't see the part where now they can have their life back. You have a person who's not wanting to live.
Yeah, I mean, they come to you with their life in their hands.
They feel worthless, hopeless. They don't feel they have any value or purpose. And then you see this whole new person come back, and that's
just part of that journey. That is really that is something that would really put a lot of joy in your work.
It's a disability you cannot see, though. You can see a physical ailment, but you don't see the depression as much, or they hide it. Many people hide it. They'll act like they're happy, but they're really not. But we call it a disability you cannot see. So it's important that you understand that,
I think too, sometimes patients test their boundaries by saying just a little bit to find out how safe it is to be able to really talk to you, and if they're going to be met with judgment, especially if there's things we have to be very culturally aware. There's, you know,
Yes.
whatever their issues are, they're going to start, I think, with, you know, revealing a little bit of themselves. And the more you build that therapeutic relationship, the more you have. I really like motivational interviewing. I think we need to learn a lot more about that in practice, because we have this idea sometimes. I love NP students when they first come into the program, you know, I'm going to just tell my patients what to do and educate them, and that's going to fix it. And I'm like, how did that work with teenagers? You know, I mean, you know, education, yes, we need to educate, but education alone doesn't fix it.
Right.
You know, I mean, they already know if they have a weight problem. They already know if they have a smoking problem. They already know if they have a hopeless problem. You know, educating them is not, it's not revealing. You know, we have to do a whole lot more than that. So we have to help them find their motivation for wanting to change or to live or to, you know, and we have tools in our toolkit, like we said, but so what would you tell a student thinking about coming into the psych program?
I would, you know, I would say that it would be worth looking into. You're going to see them as an FNP also. They're going to come to you first. So you need some basic knowledge of the medications. I see a lot of mistakes. I had a primary care. I have one who checks with me all the time before he makes any changes between my visit and his visit, but he doubled the dose one time, and it was 40 milligrams was the maximum. He would put the patient on 80. And I'm like, oh, no. So please, educate yourself on psychiatry. But one thing I do want to add is children get depressed too, and we often overlook that. And I was trying to, I think we still should be doing depression screenings in school, starting in kindergarten. The hospital I used to work at, they started at age 4. There is an infant psychiatrist at Washington University who studies, whether you're born depressed, or was mom depressed when she's pregnant, or it was at the environment that the baby's in. And you don't think of, you know, you may call them failure to thrive, but you don't think of them as depressed. But children will be depressed. It comes out in drawings, or they'll say, I don't want to live, you know, they'll put their face in a pillow. That's their attempt at, you know, not hurting themselves. But we don't want to overlook that. It can present as the class clown. The child who's in the nurse's office all the time with a stomach ache or a headache. And you need to find out what's going on with that child. You know, are they being bullied? But
I think we're all kind of scared as primary care people to dose children.
Right.
I mean, I think that is one of the areas, and I definitely did have some children that we did have to refer, some that were hospitalized, and that was always scary because it was like, you know, an adult, that's one whole world.
Right.
The kids, what's the right dose? What's the safe medicine? How do we fix that?
Well, there's therapy, there's play therapy. Works well for children because they may not be able to express themselves, but they will with toys, and they can act out and play. But also therapy is good, maybe situational. It could be a situation that's going on that you can correct, or you know, maybe some working with the parents, getting some resources for the parents, maybe their parenting skills. So a lot of the kids, but we seem to overlook kids, and the sooner you get help for a child, the earlier you're going to avoid maybe using drugs as a teenager, or, you know.
Do you think that's a lot of our problem with our kids too, as they start self-medicating? I think that is
at a younger age all the time.
You know, alcohol, drugs, different things like that, just to try to feel normal.
And they're depressed many times. And so that's something I think we should be getting. There's software for it. It's easy to use. I think once a year we do immunizations. We should be doing depression screenings in children too. And if you're working in pediatrics, that's something you want to be aware of too.
So what would be, so what's the biggest change when you switched from, I guess, the FNP into the psych role would be that therapeutic relationship, right?
Yes.
That is the biggest thing that you're learning, that is, because I mean, they do get introduced in NP school to all these medicines. Now they're going to delve a little deeper, but they never delve into a therapeutic relationship. Tell me a little bit about that.
Not usually, but you know, I think it's important to be aware of that and to be at least doing some basic screenings on your patients. But I think the therapeutic relationship, but you see, I can get them housing. I have resources to help them find employment. I can help them with food, you know, transportation.
All kinds of things.
Yes, it's just kind of
so
like,
it's kind of like a social worker too.
Sort of, yeah, very much, yes.
So you're trying to, because you are really dealing, I mean, that is challenging to have somebody that's homeless and depressed,
Yes.
you know, or suicidal, and to know when to call, you know, when is this a moment we need to call an ambulance, or when, how do we
Send them
safely
to the hospital,
plan,
yes.
you know, safely, how do we make that safety plan for them to make sure that they are safe? A lot of anxiety, I would think, as a provider, and I've certainly had it as an FNP, where they were that depressed and I've, you know, had to call the ambulance and say, you know, they have a plan,
Right.
but not having the training to know exactly how to. What are the mistakes you see commonly that practitioners make? If they had more training, they wouldn't make?
A lot of it probably is the choice of psychiatric medication, and that's very important. I see that often, or not taking, you always want to take a suicidal thought seriously. And sometimes they just, you know, they don't. They think, oh, they're not going to do anything. Or the patient will say they're not, but you get trained where you can pick up on that, ask the right questions. Sometimes they're in denial, but you'll learn to get through that. But I think mostly is medications until they can get into a psychiatrist too.
Well, I've actually seen, like, just looking at our program, the psych program is thriving, to say the least, right? I mean, you're getting tons of new students every year.
Yeah, we're more aware of mental health. It's more acceptable. Or before society, we didn't screen, we didn't want to talk about it.
Well, and I think too, nurse practitioners fill such a vital role. We are so short in mental health professionals everywhere, that, and we have, I mean, we've just come off of COVID, which has got its whole new set of psychiatric implications.
Very more severe. I think I've never seen such severity since COVID. Depression, you know, anxiety. People were separated from family.
Yeah. You know, it was so interesting because, like, in that time frame, what I noticed, I mean, we in the hospitals, we had to separate people because of the, you know, rules and everything, but the damage that did, I'll never forget, we had a patient and she was in the ICU, and it was just moments that, you know, she would look like we were going to have to intubate her, and she couldn't have any visitors. And then her husband got COVID and was in the same hospital, and so they allowed him to be in her room because they both had COVID.
Oh, okay.
And she made it.
Wow.
She completely turned around. All it took was that touch of his hand and to say, honey, come on, you need to eat something. Just try a little something for me. I mean, I don't know that we realize the power that we have in touch and in empathy and, you know, just being present for each other, and how much, you know, that really damaged people when they couldn't do that.
But I would definitely recommend if someone's interested, since even in FNP, just get some type of psych experience. I'm sure a lot of practitioners will let you shadow them or be glad to, and I've done that. They say, I'm thinking about can I spend a day with you, or, you know, and just come in and ask me a lot of questions.
I think the big barrier for a lot of people coming back for certificates is that they have to figure out how to do all the clinical hours. You know, but they are necessary.
Yes.
I mean, they really are. When you think about it, how many hours is it now? 750?
Yeah, and that changes.
That's not even enough. I mean,
it's going to go up before it goes down.
Yeah, I mean, that's like really still not enough. It's enough to get your feet wet, but you're talking about a whole new area of treatment that you're not familiar with, and you're trying to get a handle on it.
Yes.
So
very rewarding, very, very rewarding though. I don't regret it at all.
No regrets.
No, but I said there's always the FNP in me, because I'm always looking medically at a person too. So.
Well, I think that the two together are beautiful, or adult Giro with Psych. I mean,
yes.
I think Psych personally, I think Psych should be a part of every one of the disciplines. And then you have this one discipline where it goes in even deeper. But like you said, we as practitioners, it's such a part of our practice that we really need to pay.
And I do want to add one thing is they always blame the psych meds when there's any symptoms or side effects. And I say always rule out anything medical first, because that could be an emergency where I can change their psych med, but that's going to take time too. You taper off or you switch it. But any symptoms, don't assume it's the psych meds. Please remember to get them cleared medically.
Well, and that's absolutely important, because they can have a medicine that they just started or something, and then that just makes them completely confused and acting abnormal. It has nothing to do. I'll never forget the patient I had. They started her on shingles medication, and she went completely hallucinating and everything. And it was really, really a dramatic change with that medicine. She went into kidney issues, which of course, that makes you confused. And she was older. So it wasn't her psych meds at all. It was exactly like you said.
A urinary tract infection. There was, and I won't say which hospital, but there was a patient on the medical unit, and she had a mental status change, behavior change. So they put in for a psych consult. And while they were waiting for that, the patient died of a brain hemorrhage.
Oh my God.
After that, it wasn't my patient, but I always said, nope, I want him checked out medically first and cleared before
you, because I totally, before you assume it, you do have to always make sure you're looking at that medical, and that's where that FNP or that AGNP really, that background really helps too. I think that's really important to have, and a basic psych understanding is really important. Well, Dianna, thank you so much for taking time with us. Any parting words you would say to your students?
Just my psych students or FNPs thinking about going to psych. I just think they go together. I really do. Like I said, I think psychiatry is still medical because it's your brain. It's just a different organ that we're focusing on. So they do absolutely go together hand in hand.
Yeah, and we are blessed to have fantastic teachers like you who really help to, help our students get the best handle on your whole program is really, really good. So anybody out there listening that's thinking about transitioning from an FNP or AGNP and adding a psych certificate on, it'll help you. It cannot hurt. It's only going to make you better at what you do, no matter where you end up practicing. You're going to learn about the therapeutic aspect of counseling in a way, building people up and maybe helping to help them reshape their lives and change their lives. So that is a really a rewarding kind of thing. And it's worth the time. It's not that much time. It is worth the time. So we thank you for coming and being with us, Dianne. And for the rest of you out there, stay tuned. We will be with you again next week with another interesting case to try to solve the mystery of. So we'll see you next week. Bye, everybody.